Welcome back to another webinar organized by Princeton University's Bendheim Center for Finance. Fridays are webinar days and Mondays. Today, we're welcoming Daron Acemoglu. Hi, Daron.
Hey, Markus, Daron, sorry, I was on mute, sorry.
Hi, Daron. Thanks for doing it. And you will talk about the benefits of targeted COVID policies. And we will learn, how good it is to be more targeted and how to target. But as usual, I will give some introductory remarks. I want to say a little bit about what is coming up. So we had already some speakers talking on these aspects. I will talk about Ramanand's earlier talk. And on Monday, Jeremy Stein will talk about Fed Treasury credit programs. Last Monday, we had Danny Roderick talking about globalization. All of these videos you can see on YouTube as well. There are many more speakers coming up. So as I said, next Monday is Jeremy Stein from Harvard talking about Fed Treasury credit programs. The next Friday will be Paul Krugman talking about recoveries and the speed of recovery, how to best manage that. Let me come back to Ramanand Laxminarayan's earlier presentation we had in this series, because he was talking a lot about how the modeling is done in India. He introduced this India SIM model, which his institute is building, the cddep.org. You can look it up. There's a lot of interesting stuff going on in this model. There are different levels of households, which is matched to the data, different regions, different states, rural and urban regions, a lot of heterogeneity built in. But these are all agent-based models that capture the behavior, very in a reduced form. While in economics, what's really important are expectations. If you want to understand multiple equilibria, self-fulfilling hypothesis, and all these aspects, expectations are very important. One of the leading textbooks out there on this type of models, so SIR models more generally, is this Anderson and May model. So that's building on this type of models. We will learn more today, in particular from an economics perspective. And I've never seen the economics profession, in particular the macroeconomics profession, so energized to really develop this type of models and build them into economic frameworks. Of course, there are also some nice simulations out there, and Daron probably will show us some of his simulation of his model. I very much like Grant Sanderson's 3 Blue 1 Brown YouTube channel, and he talks a lot about the simulations, very interesting simulations. The RAND Corporation has some very interesting simulations for all the various states in the United States. That's interesting as well. But one aspect which I think is very interesting to me, how to do the targeting, and I hope to learn more about that. You can do ex-ante targeting or ex-post targeting. So you want to keep the flexibility to do it ex-post targeting. And Germany has just introduced the so-called emergency brake. What's the emergency brake? It is some regional targeting where you say if a region has more than 50 new infected out of 100,000 inhabitants within a week, but then the region will be locked down. So it can be a small county and you lock down this particular county. So Germany is opening up starting next week. And then they have this emergency brakes on, which is some targeting. It's more regional targeting, which is, a particular exposed way of targeting and locking down again. The question is enforceability. Of course, there's a lot of political forces at the local level which would resist the lockdown again. There's a lot of pressure to open up. But it also has an interesting implication. You want to make sure that your neighbor is not infecting anybody, is really doing some social distancing, because then the whole county will be locked down again. Is there some monitoring going on among the neighbors and so forth? So that's, I think, an interesting experiment. We have to see how it works out. And that's a particular form of targeting. Here it's more the exposed targeting. Then, in order to have these models, you have to attach a certain value of life to that. And I think Daron does this too in his model. And the question, how to infer the value of life? Typically, we do this with statistical value of life, but looking at the wage differentials between hazardous jobs and less hazardous occupations. Of course, this implies some risk attitude as well, but that's typically how the economics profession tries to attach some value of life. We have heard earlier from Angus Deaton's webinar that he's very critical of this concept of having some statistical value of life. But then the question is also, when you do some discrimination across age, how do you take the expected life expectancy into account? That's another dimension where you say you attach probably higher value of someone young because it's many more years to live, and compared to an elderly person. Is this justified? Is this moral or not? There's huge ethical questions thrown up, which you can reduce to numbers, but behind it there are important ethical questions. But you might also argue in the particular models it might not matter, because what really matters is the externality, and the externality of spreading the virus to others. And it doesn't really matter, whether what's your statistical value of life is. It's one person is equally likely to spread the virus. Then it depends more on other criteria, who is, a multi-spreader, who is not, depending how socially active the particular person is. Then I would like to conclude my opening remarks by appealing to Daron to also put his model into some endogenous growth model in order to understand the different exit strategies and different ways of testing. So going back to Paul Romer's earlier webinar, where I said it makes huge difference how long this lockdown will last and how to get out of it very quickly. And it has huge implications for all of the growth dimension, the growth path we will have subsequently. And this could be a new chapter in Daron's famous book, Modern Economic Growth, to add, SIR models into it and combine the economics from the growth models with the epidemics models. I worked on some endogenous, some growth models with money and other aspects, which I will present on Tuesday in the VMAX webinar series. But of course, I don't have the SIR component in it, and we will learn more about the SIR component today from Daron. So we're looking forward to Daron's talk, focusing very much on targeted COVID policies, how to target, and how much you can improve social welfare if you have a much more targeted approach. Thanks again, Daron. The floor is yours.
Thank you, Markus. This is a great opportunity. Thanks for organizing this series, which is fantastic. There's so many bad things that are coming out of this current pandemic. So the only minor, tiny silver lining is that we're learning to use webinars, which are so much more environment friendly than taking planes and bringing 50 people into a remote location, and hundreds of people can join. So I actually think this is something we should continue after these sorry days of the pandemic are over. So without further ado, let me start my webinar. So I'm going to try to talk about try to talk for about 35 minutes so that we have ample time at the end for questions, but I do, of course, welcome questions as well. So I'm going to draw on this paper, which Victor Chernozukov, Ivan Werning, and Mike Winston and I just released, a multi-risk SIR model, or MRSIR model, with optimally targeted lockdowns. I'm going to try to put this into broader perspective and emphasize some of the weaknesses as well as the usefulness of this type of framework. But let me jump into it before it's too late, and then we can come to some of the caveats and the broader frame later. I think we are living through a unique period, not just because of all of the disruption and the loss of life from the pandemic, but there are, I think, very few episodes in history where essentially what you might call social science models are playing such a central role. SIR model, even though it has about viruses and immunology as well as other things, but it's really a social science model at heart because it's about social contact and social outcomes. And I think a lot of our thinking about the disease, its spread, how we can contain it, is being shaped by SIR models. And one of the key policy trade-offs that everybody is aware of, although they come down on different sides of this trade-off, is between economic and public health outcomes. And there is a lot of either formal or heuristic derivation of what optimal policy or good policy would be in this SIR context. Now, the problem is, as Markus already pointed out, and people have pointed out in various different contexts, and some policymakers have already started exploiting, is that there's a huge amount of heterogeneity. occupation, productivity, location, ICU capacity, labor supply are all heterogeneous across agents, and that has implications both for public health and for economic outcomes and the trade-offs. But even more important, perhaps from a public health point of view, and indirectly feeding into the economics, is that risk factors are highly heterogeneous. So some medical professionals characterize COVID-19 as two diseases, one potentially deadly, very dangerous, one for the older population, as well those with comorbidities, and much milder for the younger population. So conditional on infection, mortality rates from the CDC, those are very similar to the Ferguson or South Korean mortality rates, a few differences from South Korea, but is here. So you can see that the age group between 20 and 50 has 1/60th of the mortality conditional on infection of the 65 plus. So this suggests that, whatever policy you do, even if you do uniform policy, it's going to have heterogeneous effects. And why is this important? Because now putting it into broad perspective, I think when historians write the account of this era in 30, 40 years' time, they will not be kind to policymakers and institutions. I think the world has largely failed both in international coordination, in providing the right public healthcare system, and developing the right nuanced policies. And I think, putting it in the context of some of my other work, this is partly because of the atrophy of some of the quality and capacity of institutions, lower emphasis on expertise and such things. And I think there's a separate set of issues to be studied there, but this heterogeneity dimension goes to the heart of it, because we really need to think about careful, well-targeted policies. So I'm going to abstract, uncharacteristically for me perhaps, from the political economy factors in the rest of the talk, and really try to think about what this heterogeneous structure of mortality rates imply for how we can deal with the COVID-19 pandemic. So more explicitly, what we do is we develop a multi-risk SIR model. The model is general, but specifically I'm going to apply it to the 3 risk groups that I have put in the previous table: young, middle-aged, and older groups. We're developing an optimal control problem. So I think heuristic optimal control is fine for policymakers, but I think we should understand some of the trade-offs, and they turn out to be very subtle. I'm going to try to illustrate that. We characterize and contrast optimal uniform and optimal targeted policies and clarify the trade-offs. So the summary of the main findings is here. What I'm going to argue is that there are big gains and significantly improved trade-offs from targeted policy. And in particular, most of the gains can be realized by very simple semi-targeted policies, which means we just treat the 65 plus group differentially in order to put them in, so to speak, protective custody, to protect themselves. And the rest is much similar to the sort of optimal policies that the literature has already considered in homogeneous setting. And a summary of that, and I think this is the best summary in my mind and in my co-author's mind, is not to take a specific ethical value about the value of life versus public health consequences, but present what the menu is. And the best way of doing that, of course, for an economist is the Pareto frontier, or some sort of frontier. So here, that's what we're showing here. On the horizontal axis, there are deaths. On the vertical axis is the output loss, which is both output loss in the current period because of lockdowns, but also loss of future foregone productivities because people die or get sick. And the origin, of course, is the best place. We don't lose any output. We don't have any additional deaths. And the Pareto frontier, therefore, is a convex-shaped outcome. And the solid line shows what that Pareto frontier is, but it's if you do the best possible policy in the abstract, but uniform policy. And then the dashed line is when you do optimal targeted policy. The two meet in 2 points. If you do no control, there's no difference because you're doing any policy, so whether it's targeted or not doesn't matter. And if you do maximally feasible control, which means you lock down everybody because life is so valuable that you're willing to put up with as much economic loss as you want to save even 1 or 2 lives, then the two are exactly the same again because you treat everybody the same. But in between, there is a huge improvement, much closer to the origin when you do the targeted policies. And I'm going to put numbers on this. Of course, the numbers have to be taken with a pinch of salt. And so those are the important caveats. Victor, Mike, Ivan, and I are not epidemiologists. There are a lot of subtleties here. These are really sensitive topics. I think that's why it's better for us and for economists in general to clarify the trade-offs rather than pass our own ethical judgments. But I will, of course, put some numbers just to give you a clearer sense. And there's a huge amount of uncertainty about both the disease parameters for COVID-19 and relevant economic parameters. For example, what's going to happen to the supply chain, how much capital can make up for labor, how much people can work from home, joint labor supply issues. So I think there's a lot here, and that's why Markus's point at the beginning is very much on target. One should think about ex post targeting, where as uncertainty about some of the parameters is revealed. We're not going to do that. We're going to work in a complete information setting here, but that's a very, very important next step. So we welcome comments, suggestions, and criticisms, and that's why I'm going to leave hopefully ample time at the end to talk about some of these. So here is the site of model that we're going to be working with, and this is a diagrammatic representation. If you take just the 4 boxes at the top and get rid of the subscript 1, that would be a typical SIR model, augmented with deaths because some of the people who are infected die rather than recover, and there might be some other choices such as ICU, non-ICU status for people who are infected. On top of this, we look at multiple groups. So here I put 2 groups, and each group has its own dynamics, but most importantly, there's a network aspect to it because the 2 groups interact both at work and in consumption, and sometimes within households. So we're going to try to write the equations for this and do the quantitative analysis for this. Of course, this is not the right forum for going into the details of the mathematical structure, but I'm going to give you a few equations so that we ground the talk and the results. So in the classic, yes, please.
So Peter Tolton asked a question whether you assume that in order to die, you have to be in an intensive care unit before.
Yes, we do. That's an easy. That's a very good question. That's what we're going to assume. I'm going to come to all of those things in a second, but it's a very easy assumption to relax. Most of the deaths are in the ICU state, meaning that they are in need of ICU, but you may not, of course, be in an ICU if the capacity of hospital beds is not sufficient. So ICU doesn't mean that you are in an ICU unit. It means you're in need of intensive care. So in a classic SIR model, new infections are some parameter beta times S, which is the susceptible population, times I, which is the infected population. So we're going to generalize this in a number of ways. First, we're going to have multiple groups, as I've mentioned. So this the new infections in group J that's going to matter. Second, we're going to explicitly recognize that the beta in the classic SIR model consists of 2 components. One is conditional on a particular type of social contact. What's the likelihood that I get infected? So if Markus and I shake hands and I am infected, what's the likelihood that Markus gets infected? But hidden in there, there's a much more behavioral, social element, which is, do we interact? When we interact, do we shake hands? Are we in the same restaurant? Are we in the same job? So, and those are going to vary between different groups by age and by other characteristics. So those are going to be these raw JKs, and that's where the network element is going to come from. Another change that we do, which I'm not going to dwell too much on in this current presentation, but I want to flag it, is that if you look at the classic SIR equation, it's a quadratic equation. It's S times I. So that's for economists, the most famous quadratic model is Diamond's coconut model. But the literature in economics has also argued that in different settings, quadratic may or may not be the right one. I think in geographic, so if you're interacting with people in a geographic space, quadratic is an excellent approximation. If you're doing it in small groups, it may not be. So we allow for a more general matching structure to deal with that. And then as usual, as in SIR models, population is divided into susceptible groups. This is the susceptible groups, infected groups, recovered groups, and the deaths, and that makes up the total population, which we normalize to 1. All right, okay. All right, so more specifically, here are the infection dynamics, and I'm not going to emphasize the math so much as to say that we're going to make two critical assumptions, which you can see in this graph. One is that we're going to assume that there is a vaccine arrival at some date t. In the paper, we take that to be a year and a half, but we vary it around. You could also do Poisson arrival of vaccine, but we think a certain arrival date is more informative about what's going on with the model and somewhat more realistic. Second, infections in group J, so that's new infections I.J, is going to depend on this beta parameter I pointed out, this MJ, which is the matching function correction, the number of people who are susceptible in group J, all of the other groups that you're interacting with, that's the summation across over different groups. But critically, there is this theta J, LJ, theta K, LK components. What are those? Well, LJ is the number of people who are locked down from group J. So they are taken out of circulation. They don't go to work, they don't go to the grocery store, or they go to a minimal degree. But we also recognize that that lockdown is imperfect. For example, this follows also in an earlier paper by Alvarez, Argente, and Lippi. And theta J is the degree of imperfection. So for every 5 people you say you should be in lockdown, 1 of them will sneak out. And then finally, there is this gamma here, which is the rate at which you recover. We can take that to be group specific, but the epidemiology suggests it's a good approximation that that's not actually that different, 18 days typically for people. And then once you have that, you can compute employment. Critically, people theta J, those who break the lockdown, they don't go back to work. They might infect other people because of the fact that they go to parks or grocery stores, but they don't go back to work. So the parameters, just to say a few more things, the gamma J itself consists of 2 ways of exiting, as I showed you in the first figure. You can either exit because you die, unfortunately, or you recover. We assume that the death rate itself is a function of overcrowding in the ICU, so that's a function of total infections. Rho IJs are the social contact rates, beta is the infection rate. LJT is the policy parameter, how much you lock down a group. We allow for essential workers from different groups so that you cannot choose to lock down everybody. That's going to be impossible. You may not want it to, but it won't even be possible. Theta J is the effectiveness of lockdown, and then WJ is the economic contribution of an individual. But we also, I'm going to talk about this in a second, we also allow for additional non-pecuniary cost of death so that the value of life is flexible, but also that's how we trace that Pareto frontier in practice. Now, this is a strict generalization of the standard SIR model. If you took the beta or the rho parameters and the gamma J parameters and the lockdowns to be the same, and each group starts at the same initial conditions, this aggregates exactly into an SIR model except for deaths. So the effects of assuming SIR for a homogeneous group is not wrong if you really want to treat everybody, except that deaths would fall differentially on different groups. But recognizing this heterogeneity.
So Daron,
yes?
Can I just ask you, some questions came up as like,
of course, please.
Some people would like to know, once you recovered, you're immune to you assume that they're immune.
So we can be flexible on that. So in this presentation, I'm assuming that you are immune, and I'm going to assume that was in the next slide. I'm going to assume that not everybody who has recovered can be identified and allowed back to work. That would be also a parameter.
I see. And Yun Yang wants to know whether you know yourself whether you're infected or not. Of course, you don't have a behavioral response.
Right. So that could be, that's a great question. So let me answer that in the context of this slide. I'm not going to explain the math in this slide, but essentially, except for saying that we set up the social objective in the way that you would expect, at least from economists. So it has 2 components. This is the cost coming from the non-pecuniary value of life. And then in addition, this is the economic cost, which includes both the fact that you're locking down people, but also that the fact that some people are dying and their future contribution to the economy are lost. So we turned this into a different problem just by some simple manipulation. But if you look at the equation at the bottom, this is the parameter that you were asking about. So the kappa J captures both what fraction of people, or it's the 1 minus kappa J, oh, sorry, the kappa J. What fraction of people are identified as as recovered by themselves and by authorities and allowed to go back to work. And that's very important when we come to testing and tracing. And in the same way that some of the infected people might miss work because they are suffering with high fever, even if they don't need ICU, or they may go back to work and infect people. So we allow for all of these interactions, but I'm not going to get into those now, just to keep the math from becoming more boring than it needs to. So the next thing I'm going to explain is how we choose the parameters. So this is, again, I want to repeat the caveat I gave at the beginning. There's a huge amount of uncertainty here. And beyond the uncertainty, there are also different priorities that different people will have about what should go into a model. So we have actually developed a GUI for this so that people can play around with the model and vary the parameters. But whatever you do, there's a huge amount of uncertainty. So here are the baseline parameters for which I'm going to show you the numbers. The fatality rates conditional on infection for the three groups. I'm going to get them from the table above. The three groups, middle-aged, young, and older, their population shares are from the census. In the baseline, I'm assuming that this doesn't matter at all, actually, or not much. I'm assuming that the 65 plus are fully retired. In practice, 80% of them are retired. And the wages of young and middle-aged in the data are very close, so we take them to be one, normalized to be one. The essential workers are supposed to be 30% of the relevant age groups. And we take theta j to be 0.75, which means that if I lock down 4 people, it's like one of them is sneaking out and continuing to infect. So that seems to be fairly realistic, given that even with infection, and then I'll talk about this when you do, for example, group social distancing in nursing homes, I'll come back to that. So in the baseline, unfortunately, as in the US and not like as in Germany, we're assuming that the probabilities of detection and isolation are 0, and the probability of identifying recovered individuals, I take that to be 100%, but that doesn't really matter too much. Gamma J is 1/18, which means essentially 18 days length of infection. And we take the beta and rho ij parameters so that the R0 is 3.5 in the baseline. That's a little high, and then we've done it with the lower ones as well. It matters for the numbers, of course, but for the qualitative patterns that we emphasize, it doesn't matter. The reason why we start with a high level, the next version we're going to go lower, is because we wanted to be conservative in every respect. And that also, not make the model be too aggressive in terms of, let's go for the economic recovery. And then that's also colors our next bullet point, that we take the death probability to be highly sensitive to ICU overcapacity. So if the ICU overcapacity is exceeded by several folds, then the death rate of people who are in the ICU need state increases 5 times. Again, that might be a little too aggressive. When you reduce that, the death rates reduce a little bit, but those are the baseline parameters. Okay, without further ado, here is what you get with optimal uniform lockdown policy. I'll compare this later to what happens if you don't do any policy in a second, but a couple of things. First of all, the optimal lockdown policy starts locking down people, more than half of the people, not all the way to the 70%, which is the allowable maximum, and then keeps these lockdowns in a gradually reduced fashion for about a year and 2 months. So it's a very, very long lockdown. Despite that, the thing I should have said is the one important parameter that I didn't put on this slide, and I was going to say it here, and then I forgot. What do you do for which value of life these are? So we take this for chi 20, which means that this non-pecuniary psychic cost of death is 20 times annual income. So putting that together with lost output, that means it's a statistical value of life per year of about 200,000, which is in the ballpark of what is used. Now, I am very skeptical of statistical value of life estimates because there's a big range and they are only valid under huge assumptions, but again, you have to start somewhere. And that's why all four of us really prefer the Pareto frontiers, which I'm going to show you in a second, which lets you choose whatever point you want. But first, to show you the form of the figures, I'm picking a particular value of this kind. So despite the fact that you have a fairly long lockdown, infections peak quite rapidly, and you get fairly bad outcomes in this case. So in particular, the box at the top right-hand side corner shows you economic loss as a fraction of 1 year's GDP, population fatalities and fatality rate, and then fatalities by group. So a couple of points. First of all, unfortunately here, even with the optimal uniform policy reflecting the aggressive assumptions we've made about the nature of the COVID-19, you have 1.8% of the adult population dying. Most of this comes from the older groups who have a 7% fatality rate. Again, that's because the ICU capacity in the US gets exceeded in these scenarios. But despite that, you don't do very well economically either. There's a 24.3% loss equivalent to 1 year's GDP. About 20% of this comes from the fact that you suffer a current recession, and about 4% or 4.5% of it comes from the fact that you're losing lots of lives and they are not going to contribute for the next 50 years. Now contrast this with the optimal semi-targeted policy. What do I mean by semi-targeted? Only treat the oldest age group differentially. So the figures show what happens when you do that. You have a less strict and shorter lockdown. It stays below 50%, and it's lifted completely in about 7 months. But the oldest group is kept under lockdown throughout until a vaccine comes. That's the most vulnerable group, and you want to reduce their interactions, and their economic contribution is lower, so keeping them under lockdown is less costly. Now you see that the overall mortality halves from 1.8% to about 1%, and the economic loss almost halves from 24+ % to just under 13%. Couple of things to note. First, despite the fact that the older group is locked down, still they account for the majority of the fatalities. Why? Because the lockdowns are imperfect, and that's the nature of the thing. Many of them are in nursing homes, or they're being cared for by their adult children or relatives, so you cannot completely isolate them. So that's captured by our 0.75 parameter values. And that is actually the reason why you still have a fairly severe lockdown in the early stages. You're trying to limit the infection of the younger group, not just to protect the younger group, but to protect the older group, recognizing that they are going to pass it to the older group despite the lockdown. So that's a very important point, and I'll come back to that in a second.
Daron, there's another question concerning, so you take the age dimension, but would you generalize that to any dimension where you say there's a group which is more susceptible than another group? And in particular, there's a question, I'm not sure whether it's 100% PC, is we know that women are less susceptible to the virus. So you can also do it across the gender, or is this? Absolutely.
I think ultimately what you want to do is do it by comorbidities and other characteristics. But the nice thing about the older group that it's observable. We have much better data. The comorbidities, it's very different across countries, and it's identifiable. And the older group is also economically more segregated. And there are better ways of doing this kind of targeted policy. That's why we started there, but absolutely, I think those should be considered as well. But I'm going to show you the next figure is actually relevant there. Mm-hmm. So in the next figure, I say, rather than do semi-targeted policy, let's do fully targeted policy. And you could do this not just with the young and the middle-aged, but imagine we have men, women, etc. And the big result here is that, sure, if you allow me as an optimal control applier to treat these two groups differentially, I will treat them differentially, but the gain I get is trivial. So look at the left-hand panel here. And what you see is that now you have a fairly severe lockdown on the middle age and a much less severe on the younger group. But look at the GDP loss. It's again just about 13%. Look at the population fatalities. It's just again about 1%. So there is very little to gain from fully targeted policies once you do the semi-targeting of treating the older group differently. So therefore, if this conclusion generalizes, what I would say is that the big targeting has to be with respect to the comorbidities that are critical. Now, let me sort of amplify that point, and then I'll come back to a couple of other
Can I just interject here?
Please, of
if
course.
You have a situation like in emerging economies or in Italy where different generations live together, how would the model change?
Yes, so I think there's an implementation aspect to it. And even before you go there, you know, the biggest problem is, for example, how do you protect people in nursing homes? And I think that requires lots of different measures. So this is why testing and tracing are going to be very important. If you have testing and tracing, you can do a much better job of protecting the older, more vulnerable group from the infections of the people they have to be commingled with. For the nursing home population, that's the nursing home aides and nurses and other people who come into nursing home. For people who are in the same household, you know, you have to do it with different sort of measures, but once we have the testing and tracing, that really amplifies the value of these targeted policies, as I'm going to show in a second. So let me amplify this point by showing you the Pareto frontiers. So first, you see the red is the Pareto frontier with optimal policy. The green and the blue are the targeted and the semi-targeted frontiers. You see that they are significantly inside, as the numbers I just showed you indicate, but they're also on top of each other. There really is very little quantitative gain from fully targeted policy once you do the semi-targeted policy. Now, what about the no lockdown? If we were to put the no lockdown here, it would be somewhere here. It's really a very bad outcome because you are exposing your, or further to the right, you are exposing your population to a lot of fatalities, but you're also losing a lot of economic output. Why? Because a lot of people who were going to be productive in the future die now, and their foregone economic contributions make this a bad economic deal as well. So lockdowns are very important, but you have to do them in a targeted way. Now, the next point I want to make is also important. So I want to now show you the same optimal policy, but for a different point along the Pareto frontier. So when I increase the value of life by another $80,000. And that's the optimal policy. Now, the top one is the uniform and the bottom one is the semi-targeted. Now, I'm going to contrast this now. I'm going to flip back to the slides for 1 second. So this was the optimal uniform policy. You see that in the optimal uniform policy, infections reach 0 before the vaccine arrives. That's herd immunity. So even though we were fairly aggressive in our assumptions, for a value of life of about 200,000 per year, the optimal policy picked some type of herd immunity. That's conceptually good because then we were comparing optimal uniform policy to optimal semi-targeted policy that was also doing herd immunity for the younger group, but of course waiting for the vaccine for the older group. So that was a nice comparison, but it's not necessarily the option that many people want. Many people don't want herd immunity because it involves these high fatality rates. So now if we jack up a little bit, not too much, but a little bit the value of life, then under the optimal policy, you get the herd immunity, you get waiting for vaccine. How do you see that? Well, you see that in 2 ways. First of all, you see that this 50% lockdown continues almost for 2 years. You start relaxing at the end only because you know the vaccine is coming, and before the infections peak, you're going to be able to get the vaccine to everybody and get everybody immune. And so you see that here also the infections are peaking. That shows that there was no herd immunity. As soon as you let people back in, because there is no herd immunity, infections are going to spike up, but the vaccine is stopping it here. Okay.
So
But
Daron,
now
can I ask you about
Just one second, Markus.
Life, sorry.
Okay, so go ahead.
About the value of life, I just would like to understand it. If the value of life is based on the annual income and you increase the annual income, let's say by 50%, then the GDP cost would also go up by 50%, or is it just the other component?
No, sorry. Let me repeat that. So if we go back, this is important.
So I know you have two components. I guess
yes,
you only
we are doing it by increasing the second component. So here we are keeping, this is, of course, everything would be invariant to just increasing WJ. So we're increasing the value of life by increasing the psi j.
I see.
So it's the psychic, non-pecuniary, non-economic cost of life. Very good. Thank you for clarifying that. But now, here is the really interesting thing. Even with this greater value of life, the semi-targeted policy does not need to wait for the vaccine for everybody, because you're still keeping the older population locked down. You can do a partial form of herd immunity for the younger population, and you keep the mortality rate lower than before because life is more valuable. And look at the contrast now. Without the herd immunity, the economic costs are even greater. So there were almost 40% of 1 year's GDP decline. So you can reduce that to 15%. And what do you do to population fatalities? Well, because value of life was greater, you had reduced that to 1.2%, but now you can reduce that to essentially 0.09%. So now you see the two faces of the benefits of the semi-targeted policies. They do very well when you are doing the same strategy of herd immunity or same strategy of waiting for a vaccine, but they sometimes enable you to change strategy as well. So let me spend 2 minutes showing you a few other things that are important, and then I'll open it up for questions. So the first one I want to show is that, one thing you can do in these network models is you can say, actually, since part of what we are doing is isolating and segregating the more vulnerable population, we can also reduce their relevant rho IJs, meaning that we make sure that there are fewer visits by outsiders to nursing homes, that younger people don't come and visit their older vulnerable relatives during this period unless they have taken precautions. So that's something that you can do precisely because you have these targeted policies in a heterogeneous risk or multiple risk model. And if you do that, you get huge gains. So this is with group distancing, and I'll just give you the bottom line. You can reduce the economic loss now to 8% of 1 year's GDP, and you can reduce population fatalities to 0.6%. Again, these numbers have to be taken with some skepticism. We have big standard errors around them, but the magnitudes, the relative magnitudes of what you're achieving are fairly robust. And then this is all still without what South Korea, Taiwan, and Germany have been doing, which is testing and tracing. If you do testing and tracing, then you're doing even better. Only a 6% GDP loss, and population fatalities are much lower. And testing and tracing is really powerful with semi-targeted policies because it helps targeting. And then finally, if you do both of them, both group distancing, protect the nursing homes, and test and trace so that people don't go and start infecting others, especially the older vulnerable population, then you get a very striking picture. You actually don't even need any lockdown for the younger group because you're protecting the older group. So now you can go do as little as 2% of 1 year's GDP, and the fatalities in the population can be reduced to 0.03%. So this is really a planet apart from the beginning numbers with optimal uniform policy. So this sort of emphasizes that once you go into this multiple group model, not only the targeted policy, but things such as group distancing, how do you manage the different groups, and how you use your capacity to test and trace, they become particularly important. Conclusion, this is very much work in progress. The numbers, as I said, are very uncertain to everybody. Ferguson's numbers are very uncertain. South Korea's numbers are very uncertain. So ours are too. There are many different assumptions one can make. Many of those are part of our model, but we've chosen some different combinations in showing you the numbers. But this is the picture that I want you to remember. The Pareto frontier can be significantly improved just with targeted lockdown. And if on top of it you do group distancing, testing, and tracing, you can have a much, much different world in which much better scientifically based policy can be used for combating this pandemic. Thank you.
Thanks a lot, Daron. So we have a couple of questions coming in. Let me first, Isaac Hakamo asks, if you looked at this model, you have about 3 million deaths. Isn't this way larger than what the predicted number of deaths are for the United States? Or can you adjust the model if you go for lower parameters? I don't know whether that's true, but
I didn't understand the question. Sorry, Marcus.
He claimed that the number of deaths you showed are 3 million, which is way more,
yes,
way larger.
Yes, that's absolutely right. That's why I'm saying I'm 100% right. We made very aggressive assumptions to make sure that the model doesn't minimize the public health consequences. So I showed you those numbers because those are the ones we started with in the baseline, but in the next version, we're gonna have lower R0. So essentially, there are two aspects to the death rates that are very important. One is what happens to what is the R0? And the R0 that you have from China in January may not be the relevant one because people understand the disease, they wash hands, they wear face masks, that's gonna reduce the R0, which in our model is the beta times the rho parameters divided by gamma. So we started with a relatively high one, not to minimize the spread of the disease. And then we also wanted to choose a parameterization that made the model not go to herd immunity immediately. Because in these models, it's actually one thing that public health experts don't always discuss, but it's very easy for the model to say, just go for herd immunity. So we didn't want to do that. And one force for that is what you saw in Italy. The ICU system gets overwhelmed. So we put very convex death rates as a function of, and those two imply very high death numbers if you don't do anything, or if you don't do these sort of targeting policies, or you don't do some sort of testing and tracing.
So another question is about switching. Let's suppose you started your policy as a uniform policy and you want to now switch to a targeted policy in the middle. So this comes in particular, so Manuel asked this question, and also comes from Indians, where India imposed a very uniform policy and now they go for regional targeting. How would the model work if you start in the middle? Can you incorporate that somehow? Or?
That's an excellent question, and you can do it very easily in the model. I don't know the answers to that. But essentially what that amounts to is that one thing I did not say, one of the set of parameter choices I didn't mention just because time was short, is where do we initialize the system? So we initialize the system at 1% infected and very little recovered. So what that would involve is that you would run the uniform up to a certain point, say 2 months into the disease, so that's day 60. And then at day 60, you calculate the stocks of infected, recovered, and susceptible from the model by group, and then you feed these as the initial conditions, and then you do the optimal targeted policy from then on. We haven't done that, but we have checked that the conclusions that I'm reporting here are very robust to changing initial conditions. So the proportional gains from that point onwards would be similar, but of course, overall proportional gains won't be because you would have already suffered a lot of peak infections at the early stages.
Some other questions concerning, there just was understanding the figure that the optimal lockdown goes down to 0. That's because of herd immunity or not?
Yes. So that's a great question also. Let me sort of show again this picture. So if you look at the optimal uniform policy here, you see that the lockdown hits 0 before the vaccine arrives. That's essentially a telltale sign of there is herd immunity. And that's why, and you can see that on the right-hand side, the infection rates don't peak even though people are now back in the population, they're mingling just as usual. So that's herd immunity. And again, there are some public health specialists that say that's the only way out, but many people are very against herd immunity. We don't want to take a position. So if we go to this Pareto frontier, as you go towards the bottom right, those are points of herd immunity. If you go towards the upper left, those are points of no herd immunity, wait for the vaccine. So you can choose whichever point that you want. And you can see that the gains are going to be substantial, both in terms of economic and public health consequences in both cases. So this is one where you don't go for herd immunity. Why? How do you see that? You see that essentially the lockdown is kept until the vaccine comes. It's relaxed just a little bit before the vaccine because you know the vaccine is coming with certainty and infections are not going to peak much during that period. You can deal with it. So you let that happen. And then you see that with this, let me just annotate that again. You see this kind of here is the telltale sign that there is no herd immunity. So again, I think this is a very sensitive issue. We do not take a position. We do not want to take a position as to whether you want herd immunity or not. But what the model says is that with targeted policies, you can really protect the most vulnerable group. And then this discussion becomes more moot.
So another question concerns, it's from Amy Chen. I would classify as a Lucas critique question. Wouldn't you expect that social distancing changes based on the ICU capacity? So if in the US you have a very limited ICU capacity, people are more careful and they do more social distancing compared to Germany where there are huge ICU capacities.
That's a great question.
Can the model incorporate this?
Hi, Amy. Thanks for the question. Yes, I think that's an excellent question. No, our model doesn't incorporate that. So one missing piece in our model, and of course, you don't want to put everything in the model, is that we don't have endogenous behavior. So there are a couple of models that are coming out now, one by Garibaldi, Moen, and Varieties, one by Jarosh, Farboudi, and Scheimer, and a couple of others, which have endogenous behavior. So then the infection rate, as well as ICU capacity and other things, are going to influence people's own protective measures. So we don't have that, and that's the reason why our mortality rates are exaggerated, because they assume that if policy is not capable of doing something, people themselves won't take precautions that may or may not be less costly. The reason why we start with this benchmark is because we know from economic analysis, and there are several papers pre-COVID on this, including some that I did, where because of the externality in this sort of network settings, you're never going to do the right type of precautions. So the endogenous social precautions that people do is never going to be sufficient. And so we characterize the optimal lockdown, and then there's a question of how you decentralize that between endogenous behavior and enforced behavior, where enforcement could be either by norms, that's very important actually, something we need to look into, or by law and regulations. So I think those are really super interesting questions, but that's not where we wanted to go in this first paper, but excellent question.
So another question I have is, you said this is a model of certainty and everything is, all the parameters are uncertain. How should I can play with different parameters in I should do some advertising for your online unit where you can play with various parameters. But should I then just average over the outcomes, or how should I think, or
That's another excellent question.
This there's a lot of non-linearities built in. So how do you deal with that?
Perfect question. Wonderful question. Thank you, Marcus. I've said this to several people. This is a perfect setting for robust control. So you want to take some reasonable worst case scenarios, taking that uncertainty into account. Now, unfortunately, we don't even know enough parameterization of the uncertainty to be able to do that yet. We're sort of, enough data is coming from different countries that might enable us. And second, Hansen and Sargent, for example, have made enormous progress in bringing robust control into economics, but I think there's a lot of disagreement about what's the right type of robust control, what are the right penalties, or do you want to do min-max, etc. So I think that's going to be a big boost to that literature that will have really insightful advice for policy.
And you would prefer the robust control rather than a Bayesian approach that I have of each parameter distribution? And
I think both. I think that would be an excellent idea too.
Okay. But your simulations could allow for that, I guess.
Yes. So the GUI, that's on the online you can already just slide things around and see how the policies change, how the numbers change.
Okay. So there's a number of other questions which would like to get some insights what your model can deliver across the United States, across various states, because there's some heterogeneity in preferences, which I think your Pareto frontier can take into account. But there's also some learning if some states open up earlier and then subsequent states can learn from that. I don't know whether your model has anything to say.
I think that's another excellent point. I mean, once you allow for uncertainty, there's a huge demand for experimentation. Experimentation, of course, is a very ethically charged issue. You know, people don't want to be guinea pigs, so you have to handle that very carefully. You cannot say, you know, Worcester should open up and then we should see whether that's good or bad, and then we apply that to Boston. But if it's bad, lots of people die in Worcester. Well, there are ways of doing experimentation that are less costly. For example, if you do experimentation in places where the population has low comorbidities and the ICU bed capacity is high, then you can get the benefits of information, sequential sampling without the huge costs. But again, these are topics that require, you know, real good expertise on the side of the public health professionals, on the side of economists advising the administration, both state and local, and federal and state. And, you know, I think the situation in Germany, I think this is the sort of advice that you can give to German policymakers. In the US, CDC has been an utter failure. The Trump administration has been an utter failure. So I think, you know, for them, for us to say to them, you should do experimentation, I don't know how reasonable that is, but I think simple policies, I think, should be on the table when they are better than the ones that are being applied. So that's why we like the semi-targeted policies. They're simple to implement. These groups are already segregated. Their gains are big, but obviously I think there is much more to learn from the science of epidemiology and economics being combined here.
I know you have a hard deadline and we hit 1:30. I want to thank you big time for giving this talk and for making the strong message that we should actually treat elderly people differently than young people. And I hope this will be picked up all over the world and also including the United States. Thanks again. And I want to advertise again, on Monday is Fed and Treasury credit policy programs. And then next Friday is Paul Krugman talking about the optimal recovery or the exit and trade-offs in this space. Okay, thanks again, Daron. And
thank you, Markus. Thank you, everybody. Those were excellent questions, and thanks for listening. It's great to be sharing these ideas with you. Great. And we welcome additional comments and suggestions. Thank you.
Great. Thanks.